everyone and welcome back again. I am Samapti Sinha Mahapatra, your zoology teacher teaching in Sri Chaitanya Institute. Yes students, we were discussing about the chapter chemical coordination and integration, and we have discussed till pancreas. We also discussed about diabetes mellitus in the previous class, and I told you that in the next class we are going to discuss about the two types of diabetes mellitus. So just a quick revision to what was diabetes mellitus. Diabetes mellitus was a condition when there is a hyperglycemia seen, and what is this hyperglycemia? Is the increase in level of blood glucose. So are you able to remember that? What were the conditions that caused increased level of blood glucose? Yes. Now let us discuss the two categories of diabetes mellitus. One is type 1 and other is type 2, and let us see what is the difference between these two. On this side of the board, I have written it as diabetes mellitus type 1, which is also called as insulin dependent diabetes mellitus. Insulin dependent diabetes mellitus stands for IDDM. And when you talk about the type 2, it is called as non-insulin dependent diabetes mellitus, NIDDM. Why am I saying that type 1 is insulin dependent diabetes mellitus and type 2 is non-insulin dependent diabetes mellitus? That we are going to see in the later points. I have mentioned it there. Just remember IDDM and NIDDM. Alright, when you are saying type 1, it occurs at a younger age, and since it occurs at a younger age, it is also called as juvenile onset of diabetes. It is called as juvenile onset of diabetes. Whereas when you're talking about the type 2, it occurs at an older age, usually old age. That is why it is called as maturity onset of diabetes. So younger age, type 1, juvenile onset of diabetes, and type 2, which is occurring at an older age, which is why it is maturity onset of diabetes. Okay, now looking at the other point, it is less common, but this type 2 is very common. Talking about this, again students, it's an autoimmune disease. So if I ask you type 1 and type 2, among these, which is an autoimmune disease? So type 1 is actually autoimmune disease, and you know now very well that you're going to attack your own body cells, and in type 1, what you do is attack the beta cells. If you can recall, beta cells were the cells that produces insulin. If I damage these beta cells, what will be not produced is insulin. If you have no insulin, then insulin functions will not be performed. And the function of insulin was to reduce the blood glucose level. If insulin is not there, blood sugar level will be high. That is hyperglycemic condition. And since in this condition you actually see the deficiency of insulin, that is why it is called as insulin dependent diabetes mellitus. Insulin dependent because you actually have a deficiency of insulin. When you talk about this comparative with the type 2, you say that it's more common, but why is it happening? Here the beta cells are working absolutely fine. Insulin level is normal, but what I have written is receptors become less sensitive for insulin. They're becoming insensitive. Now why is this happening, students? If there is a prolonged hyperglycemic condition. In the very first class, we have already discussed that the hormones require receptors for their action. Now, insulin for its function also will bind with the receptor. If you have prolonged hyperglycemic condition, you are telling your cells to do work continuously. Imagine yourself, if I am telling you to continuously study for 24 hours, your brain is going to be blocked, right? So in the same way, if you are asking your receptors of insulin to continuously work because you have continuous level of increased glucose, there would be a time the receptors will become less sensitive. And when it becomes less sensitive, even if you have normal insulin level, it is not going to reduce the blood glucose level. Hence, Actually, insulin is not less. The receptors are becoming less sensitive. That is why it is called as non-insulin dependent diabetes mellitus. Getting my point? Actual deficiency of insulin, but the receptors becoming less sensitive, hence hyperglycemic condition. In the last point, I have written that in type 1, daily injection of the insulins are required because insulin is not formed, beta cells are being damaged. But in case of type 2 diabetes, injections will be required only if the normal oral medications of insulin and your normal diet is not proper, okay? Only in that condition you require the injections of insulin in type 2. So that's the comparative between type 1 diabetes and type 2 diabetes. In the next class, in the next part, we are going to discuss about the next gland, which is testis. Now let us start with the next gland, which is testis. Talking about testis, if you see the location of the testis, testis is located in males outside the abdominal cavity in the scrotal sac. In junior classes, we have already studied that the purpose of the testis to be located outside the body in the scrotal sac is to maintain a lower temperature than that of the body temperature. Looking at the origin of the testis, that is mesodermal. Now students, since we are studying the endocrine glands, so definitely testis is one of the endocrine glands, but that's not the only function of the testis. I have written it over here that the testis acts as a primary sex organ as well as it is acting as a endocrine gland. When I say it is acting as a primary sex organs, how do you define a primary sex organ? The organs where the process of gametogenesis or the gamete formation is taking place, all those parts are called as the primary sex organ. When I say all, that means in a male, it's the testis where spermatogenesis is taking place, and in females, it is the ovary where the oogenesis is taking place. So definitely it is acting as primary sex organ because the sperm formation is taking place, which is called as spermatogenesis. When you are saying it's an endocrine gland, so it is having the hormone. Now the hormone of the testis is called as androgens. And the primary androgen that the testis produces is testosterone. Also, if you remember, hypothalamus has a hormone called as GnRH, which is gonadotrophin releasing hormone. This gonadotrophin releasing hormone acts upon your pituitary gland, anterior pituitary, that produces a hormone, if you remember, FSH, that is going to stimulate the formation of sperms, and also releases LH, that acts upon which cells, if you remember, Leydig cells, that ultimately produces androgens. Why did I say that? Is because these androgens, which is primarily testosterone, is produced by the cells called as the Leydig cells, or you know the other name called as the interstitial cells. We are also going to talk about these cells in the human reproduction chapter. Now, all the functions of the testosterone is very, very easy, because looking at a male, all the characteristics that a male has that differentiates a male from a female, all those characteristics are controlled by the male hormone androgens. So, I have mentioned quite a few functions of the androgen. Looking at the first function, it controls the process of spermatogenesis. It indirectly controls the formation of sperms. Now looking at the second function, it helps in the descending of these testes in the scrotum. Students, you will be learning in next chapters that during the initial development, testis is present close to the kidneys, attached with the kidneys, and during the 7th month of pregnancy, the testis descends down in the scrotal sac. And this descending from upward towards the scrotal sac is taking place under the influence of the testosterone. Very, very important. Now looking at the other function, it also helps in the growth and development of the other male accessory sex organs like the vas deferens, like the seminal vesicles, like the epididymis. So it also helps in the growth and development of the accessory sex organs. Alright, the male pattern of hair distribution, too much of hair on the body, appearance of beard and mustache, that is also controlled by the male hormone testosterone. Okay, this step, erythropoiesis. Yes, androgens are also responsible for increase in the RBC number. Can you recall some of the hormones that I already mentioned is also promoting erythropoiesis? Hormones like cortisol, hormone like thyroxine, and hormones like androgens also promote erythropoiesis. The low pitch voice in the male is also because of the hormone testosterone. This you might have come across in the chapter breathing and respiration about the vocal cords difference in a male and a female. And that difference also is responsible for the low pitch of voice that a male has under the influence of the testosterone. The aggressiveness is also controlled by the male hormone testosterone, and the male sexual behavior is controlled by the testosterone. The last function, not the least, is again very important, the anabolic effect on protein and carbohydrate metabolism. There is a masculine development during the growth phase, and under the influence of this testosterone, not the breakdown, not the catabolism, actually the anabolism is seen, the formation of protein is seen. Again, very, very important functions related with the testosterone. So we are done with the different functions of the testosterone. Now we are going to discuss about the different disorders related with testosterone. Now let's start with the disorders of the testes. So there's first disorder which is called as eunuchroidism. Eunuchroidism is because of the failure of production of testosterone. It is specifically because of the failure of production of testosterone. You can easily tell me the symptoms related with it. If you don't have testosterone, the male accessory sex organs will remain smaller in size, right? Because that was having the control over it. The sperms will not be produced, failure in the sperm production. The low pitch of voice will not be retained. The beard will fail to develop. So all the conditions related with the testosterone you won't see in the patients of eunuchroidism. No testosterone, no low pitch voice, no beard and mustache, failure of sperm production, as well as the accessory sex organs like penis, the seminal vesicle, prostate gland will remain smaller in size. Now, very popular disorder called as gynecomastia is actually the development of breast in a male. That's gynecomastia. And this is because of the disturbance in the androgen and estrogen ratio. Because of the disturbance in the androgen-estrogen ratio. What happens if in a male before puberty level of estrogen is quite a bit high, and after puberty androgen level is quite a bit low. Estrogen high before puberty and androgen lower after puberty is going to cause a disbalance, and that leads to the development of breast in a male called as gynecomastia. Also, I would want all of you to please make a point of castration. When you know the word meaning of castration, castration basically means the surgical removal of testes. The surgical removal of testes. A very good example of castration, you know, the bulls are being converted into bullock by castration process. You must be knowing this, that bulls are really aggressive because of too much of testosterone. But if surgically the testes are being removed, which is castration, the bullock is comparatively less aggressive. You can easily use it for your other work purposes. Alright. Now moving on to the next gland, that's a female, related with the female, called as ovary. Now compare the testis that we have already covered and the ovary. Testis was also acting as a primary sex organ as well as a gland. The ovaries are also acting as a primary sex organ as well as the gland. Testis was also having mesodermal origin and your ovaries are also having mesodermal origin. Now talking about the primary sex organs, you clearly know now the organs where the gametogenesis process is taking place. Talking about the primary sex organ, ovary, oogenesis, which is the gamete formation in a female, is taking place. Hence ovary is a primary sex organ. Why is it a gland? Because it has got different hormones. It has got estrogen, it has got progesterone, it has got relaxin, it has got inhibin. Various hormones released at different type, having some certain functions that we are going to take up in the next part. Now let's move on to the hormones of the ovary. The very first hormone that we are going to talk about is estrogen. Now students, you can write the spelling as OES, as well as you can skip that O. There's just a difference between British and American English. That's not a problem. Let us look at the estrogen. I have written that it is produced by the follicles mainly under the influence of FSH before ovulation and corpus luteum after ovulation. Now you are listening these terms maybe for the first or second time. What is corpus luteum? What is ovulation? So I'm going to give you a brief idea about the follicles, ovulation and everything. Although in human reproduction you will be studying this part in detail, but just to understand how the hormones are produced, I would want to tell you just a little brief idea about what these follicles are. In the ovary, you have got several follicles. I have shown in this color follicles inside which you have the ovum. Now these follicles mainly grow by the hormone of pituitary, which is FSH, that you already know. Follicle stimulating hormone. Name itself is follicle stimulating. So it is growing, all the follicles are growing under the influence of follicle stimulating hormone, which is having the oocyte. What is happening? These follicles are producing estrogen. These follicles are producing estrogen. I have written on this side of the board, it is ovulation. Do you see, while before ovulation, these follicles are producing estrogen. That's what I have written, that produced by follicles mainly under the influence of FSH before ovulation. But what happens when there is an excessive level of LH? When there is an excessive level of LH, this excessive level of LH is going to break this follicle, okay? It is going to break this follicle and release the ovum. It is going to release this ovum. Releasing of the ovum means ovulation. So high amount of LH breaks down this follicle, ovulation is taking place, and what is left with us is now called as this yellowish body, corpus luteum. Now this corpus luteum has the ability to produce estrogen. But this estrogen which is produced by the corpus luteum, that is after ovulation. That's what we have written, that estrogen is also produced by corpus luteum but after ovulation. And also this corpus luteum produces one more hormone, that is progesterone. Here only you can compare that estrogen is produced before as well as after ovulation, before by the follicles, after by the corpus luteum. But progesterone is only and only produced after ovulation by corpus luteum. Now let us look at some of the functions of this hormone estrogen. It is responsible for development and maintenance of the female sexual characteristics. The female sexual characteristics like the high pitch of voice, like the female pattern of body hair, like the different characteristics that you see in a typical female, that's the deposition of fat around the thighs, during the puberty. Also, it is influencing the female menstrual cycle. So, all the characteristic students that you see in a female, the distribution of hair pattern, the pitch of the voice, the hair distribution, the fat distribution, the regulation of menstrual cycle is mainly under the control of estrogen. Now, talking about the second hormone, this is function of progesterone. Students, you will be familiar with this progesterone in the chapter that we'll discuss later, that this progesterone hormone is actually called as the pregnancy hormone. This progesterone is called as the pregnancy hormone. Now, why is it called as the pregnancy hormone? We are going to look for that. We have already said that progesterone was produced by this corpus luteum and it is produced only after ovulation. That's what I have written here, that it is produced only and only after ovulation by corpus luteum. The functions, when you see, it is responsible for maintaining a very, very thick endometrium. What is this endometrium? This endometrium is the wall of the uterus, and the wall of the uterus is thickening under the influence of this progesterone, which is very, very important, required for implantation, pregnancy to be sustained, to be carried, which is why progesterone is called as a pregnancy hormone, as it can support pregnancy by thickening the endometrium. Is it clear? Now, it is also preparing the mammary glands for lactation. During that process, under the influence of progesterone, mammary glands are preparing for the lactation process. Also, if you see, it is going to inhibit ovulation. If there is a high amount of progesterone, then the ovulation will not take place. So that's the comparison of progesterone and estrogen. We are going to discuss about the two hormones which are remaining, relaxin and inhibin. So the remaining two hormones of the ovaries is relaxin and inhibin. Talking about the hormone relaxin, as the name is suggesting, relaxes. First of all, let us see which part produces this hormone relaxin. So it is produced by the corpus luteum itself, and when you are talking about relaxin, it is only produced when the delivery of the baby, that is called as parturition, is taking place. Whenever the parturition or the delivery of the baby is taking place, at that time the relaxin by the corpus luteum is produced, and that relaxin acts upon the pubic symphysis. You all know that pubic symphysis is a cartilage. It acts upon that pubic symphysis. It is going to relax that pubic symphysis. It is going to dilate the cervix area, which is forming the birth canal, so that the easy passage of baby is taking place. So relaxin by the corpus luteum, relaxing the pubic symphysis during the parturition process. Talking about the last hormone, inhibin, that is again produced by the corpus luteum, and just remember directly that it has a role in giving a negative feedback. It gives a negative feedback. That's why I have written it as inhibits. It gives a negative feedback to follicle stimulating hormone of the pituitary, specifically the follicle stimulating hormone of pituitary, and gonadotrophin releasing hormone of hypothalamus. So those were the hormones of all the endocrine glands till now we have discussed. But students, there are also some other organs to produce some other hormones. Let us discuss in brief what are the other parts in your body also involved in the other hormone production. Talking about the first part, heart. In the chapter excretion, you have done about the factor called as ANF. I have written the factor ANF, which is called as atrial natriuretic factor. Atrial natriuretic factor. This ANF produced from the wall of the heart is responsible for the decrease in the blood pressure, decrease in the glomerular filtration rate, and vasodilation. It dilates the blood vessel, it decreases the blood pressure, it decreases the GFR. That's the hormone produced by the heart. Talking about the hormone produced by kidney, you have got in kidney, juxtaglomerular cells, the JG cells, juxtaglomerular cells, producing a hormone erythropoietin. That shows erythropoietin helps in RBC formation, which means kidneys are also somewhere regulating the process of erythropoiesis with the help of the hormone erythropoietin. Also, there is one more hormone, that is calcitriol, students. Do you remember this calcitriol somewhere? We have discussed in the calcium homeostasis that calcitriol also somewhere was helping in this calcium homeostasis. Calcitriol, which is a precursor of vitamin D, is also helping in the absorption of the calcium ion, and that's how it is very, very important in maintaining the high blood calcium level. We have also got some other organs producing some other hormones that we are going to take up in the next class. Till then, please study this all from NCERT as well. Take care, stay happy, bye-bye.